Good morning, everybody. The first topic is etiopathogenesis of central serous chorioretinopathy and the role of imaging. Central serous chorioretinopathy is a multifactorial disease, and there are causes, identified causes like increased corticosteroids. Either it can be exogenous or endogenous. Type A personality, which results in increased catecholamines. Then also hypertension, smoking, alcohol, antibiotics, antihistaminics, allergic diseases, and even H. pylori infection are also related with central serous chorioretinopathy. But mostly it is idiopathic. This is a word diagram we are trying to put in short how it happens. If we see this choroidal hyperdynamic choroidal circulation and then choroidal hypoperfusion, and both results in venous dilatation and results in increased hydrostatic pressure in choroid. And how the corticosteroids act, corticosteroids increased nitrous oxide results in, this increased nitrous oxide results in vasoconstriction of the choroidal vessels, which results in choroidal hyperpermeability and comes to the final pathway of increased hydrostatic pressure in the choroid, which damages the retinal pigment epithelium tight junction, resulting in breakdown of RP barrier, which causes retinal detachment. Imaging, why we do it? The evaluation and differentiation from other entities like Vogt-Koyanagi-Hara syndrome and choroidal neovascular membrane for treatment purpose, to see the progression of the disease and for better understanding and research, of course. Commonly used tools for the imaging are color and infrared photographs, digital fluorescent angiography, Fundus Autofluorescence, optical coherence tomography, Indocyanine green angiography, and also multifocal ERG and microperimetry. Fluorescent angiography is the basic test which we usually do before treating and even for assessing. At the acute phase, we got ink blot leaks and then also the smokestack pattern. Then pigment epithelium detachment cases, we get pulling of the dye. These are the few of the cases we will show you, that we can see the ink blot pattern there. And there is a smokestack pattern we can see from the right upper corner of the photo, then the left lower and the right lower you can see. And this is a reverse smokestack pattern. We can see the dye is pulling downwards. In chronic cases, we get multifocal leakage points. You can see in this case is about 3 we arrowed, and there are another 3-4 multifocal leaks. And there is also retinal pigment epithelium window defects, and definitely there are atrophic tracts. This is one of the photographs of the chronic central serous chorioretinopathy. You can see in the left upper photo that there are subretinal band formation, and the inferiorly you can see the serous detachment, and left upper photo if we see there is subretinal fibrins in yellow dots. So this is the photo of the same patient angiogram. We can see the RP window defects in the left photos, and the right photos if you see there are pullings you can see, and those the hyperfluorescent area, you are seeing hyperfluorescent area due to the subretinal bands. So then we come to fundus autofluorescence. This is an adjunctive tool, can differentiate between acute and chronic phase. Autofluorescent densitometry measures photopigment density, which show delayed recovery after subretinal fluid resolution. Autofluorescent pattern correlates with vision. So there are two types hyper-autofluorescence we get in areas of neurosensory detachment, and subretinal yellow dots in chronic cases may become visible after absorption of subretinal fluid, and hypo-autofluorescence at the leak sites and subretinal fluid sites. You can see the yellow circle marks the fluorescent foveal avascular zone, and outside that is the hyperfluorescence, which correspond in the OCT in the right lower photo with the neurosensory detachment, and also there are some intraretinal fluids. Now we come to the Indocyanine green angiography photograph. So insights about the choroidal pathology you can get by this. Definitely it helps in treatment with PDT. There are features of delayed choroidal filling, early phase, mid phase, and the late phases. This is the early phase photo. There will be dilated choroidal vessels. You can see the yellow circle, and the hypoperfusion areas of the choroid you can see. The mid phase will show punctate hyperfluorescence areas, showed by the arrows, and the late phase indocyanine green angiography shows choroidal hyperpermeability, which is usually greater than the fluorescent angiography leaks and widespread and commonly present in the fellow asymptomatic eye also. Then we come to the optical coherence tomography, thickness and volume in 3 dimension, real-time structural assessment, and it can show us the subretinal fluid, pigment epithelium detachment, assess progress and treatment response, and helps differentiate to unsuspecting subretinal lesions. So there is, we can see the color photo right up is the infrared, and the left lower is the fluorescent angiography photo corresponding OCT. We can see this small chink of subretinal fluid, and this is cystoid changes and ISOS junction disruption is associated with poor visual outcome, which we can predict by the OCT. Here one OCT photo of pigment epithelium detachment with central serous chorioretinopathy. You can see multiple CSCR in the left down photo. There are another photos, and the right lower photos you can see the fibrin, and see the leaking points is slightly elevated up. Cystoid changes in the chronic central serous chorioretinopathy photos you can see. There is a 30-year-old male patient and diagnosed with defective vision for 2 years, visual acuity of 624, and there is some difficulty in diagnosis. If you see in the fundus photo in the left side of the OCT, it looks like some macular degeneration, but when we do the OCT, you can see the right side, there is the fluid which helps in the diagnosis as CSCR. So there is another photo, you can see the visual acuity 618 and 3 months visual acuity 624. Visual acuity, why it is becoming less, and we can see in angiography there is no leak. So if we see there is subretinal fibrin deposition in 3 months, which resulted in the decreased vision. So we may not have to do again repeat angiogram to see the things, only the OCT can tell us why the vision is dropping. So then is enhanced depth imaging in the current OCT machines. We can see the choroidal hyperpermeability is associated with increased subfoveal choroidal thickening, which you can see here. And there is another case we will see differential diagnosis. If we see looks like a CSCR leaks and ink blot pattern, but if we do the ICGA angiogram, we can see the small polyp-like thing, and if we do the OCT, it confirms our diagnosis, and we treated it with the PDT. Thank you.